Right. Thank you so much, Gary, for the introduction. And thank you, Holly and Kelly, for asking me to present tonight on prostate cancer imaging and diagnosis. And it's a real pleasure to be here tonight after sending many of my patients down for sessions like these from the Cowichan Valley. It's just a huge resource for patients. And I know that all of the patients that I've sent down have been very helpful. Fortunate, thankful, and very appreciative of the time and the efforts that you all put into organizing these events. So thanks for coming. So let me see if we can get the next slide here. Okay, here we go. So as just as an outline, I'm going to talk a little bit about the diagnosis of prostate cancer, sort of landing at a diagnosis of prostate cancer and how a lot of you have come to be here today. We'll talk about the imaging used in both the workup of prostate cancer when you initially get your diagnosis, but then also after treatment, what may come down the pipeline for you. And look at one new modality that's available in the diagnostics and workup of prostate cancer, both at initial diagnosis and also at time of recurrence, if that does come. A few disclosures: I've had a couple of educational grants over the years and a guest speaker honorarium, but shouldn't play any role in today's discussion. Yeah, I'll speak up. I'm getting feedback from the mic, so I don't know. Is the mic for this room or for Zoom? This microphone is for the room? Oh, there we go. Oh, that's better. Okay, maybe I'll hold. Okay, sorry about that. Okay. So a few disclosures, but no impact on today's discussion. So as Gary said, I'm a urologist. I work in Duncan, and I've been there for 3 years. I'm originally born in Port Alberni, so I'm an island guy. And I did my Bachelor of Science in Biochemistry at the University of Victoria. So it's nice to be back on sort of local ground here. I've golfed at this golf course a couple of times many years ago. I did my medical degree in the Southern Medical Program in Kelowna, based through UBC, and then finally did residency in urology at the Vancouver site. So yeah, I've been working for 3 years and been really enjoying my time back on the island, being closer to home and helping out patients that were kind of in my own backyard through my upbringing. So it's been very rewarding. So let's start by looking at what is a prostate. I get a lot of questions about just simply what is it and what does it do and where does it live? And it's a structure that lives between the bladder and the urethra, and the urethra actually passes through the prostate. And you can see it's this yellow structure kind of right in the middle of the screen here. The pointer coming up on the Zoom for you guys. So it's this yellow structure here. It's involved in a little bit of urinary continence and ejaculatory function. You can see the structure behind here. This is called a seminal and this stores kind of the food supply for sperm and supplies ejaculatory fluid. So when orgasm is achieved, this will all kind of go with the urethra and have an ejaculation. And the prostate has a couple of sphincters, one that's above, one that's below, the internal and external sphincter, and that's where your urinary continence is controlled and what may be impacted at time of future treatments, whichever that may be. So that's the location of the prostate, and you can see it's close proximity to the rectum here, which is this kind of tube-like structure in the back. And that's where you can sort of feel the prostate when you have your physical exam or have your prostate examined in the doctor's office. That's kind of what they're feeling. It's the back wall of the prostate. Prostate cancer comes in different shapes and sizes, and you can see on the screen here a few of the stages and kind of how the progression of prostate cancer may look if you were to cut a prostate in half from stage 1, which is very small and localized within the prostate, stage 2, which is kind of bigger or maybe on both sides of the prostate or representing more than half of a prostate. Stage 3 is where you start to get extension of the prostate tumor just outside of the capsule of the prostate or the periphery of the prostate. And then stage 4 is where you start to get out of the prostate and into the surrounding structures like the lymphatics or the bladder neck and different things that live around the prostate. So the higher you go up this scale, the more aggressive we think the prostate cancer is, or we know the prostate cancer is. So most times prostate cancer is picked up with usually a blood test or a rectal exam that is abnormal. So feeling a nodule on the prostate that your doctor picks up. A lot of times people are asymptomatic when they present with prostate cancer because it's generally caught very early with screening practices. It's a great test for tracking prostate cancer, but does have some issues with screening. So some people may get worked up or receive biopsies or different invasive things for an elevated PSA or a PSA that's out of the normal range for reasons other than prostate cancer. But the one that we worry about most is prostate cancer causing elevated PSAs. Other things like BPH or benign prostatic hyperplasia, enlargement of the prostate, urinary retention, recent instrumentation like a cystoscopy or a rectal exam can raise your PSA, and any infection or inflammation type event can cause your PSA to go up as well. So typically, once you get your diagnosis or leading to the diagnosis, it will be brought on by an abnormal rectal exam, an elevated PSA that's above normal range or a trend upwards at a concerning rate or a certain rate. Or nowadays, we're also seeing magnetic resonance imaging or MRI being used in the diagnostic workup for prostate cancer. And this is new, probably within the last 10 years, becoming more mainstream and more acceptable as a form of diagnostics. Prostate biopsy is probably bringing back a lot of bad memories to people in this room because it's not a very enjoyable procedure, but it's really the only way to definitively confirm the diagnosis. This is where you get a tissue sample, where you get a piece of the prostate, and the pathologists look at it under the microscope and can tell for certain whether or not it is in fact cancerous or not. MRI and different sort of imaging tests sometimes will help give us an idea that there could be a cancer present, but it's not 100% definitive until you have a tissue sample. So that's why a lot of times doctors will recommend a prostate biopsy, even when they think the diagnosis is pretty clear, if it will help kind of manage things. So there's two forms of prostate biopsies that we possibly will do. There's a transrectal ultrasound guided biopsy or a transperineal. And the transperineal is a newer technique that's starting to come about more frequently these days. But the traditional way is this transrectal approach here, where you use an ultrasound gun or an ultrasound probe or other, which goes into the rectum and it localizes the prostate. And then there's a little needle that comes out under a controlled fashion where they'll freeze the prostate with local anesthetic and then take several needle cores of the prostate, and they send those little biopsy cores to the lab. So sometimes they'll take a standard template of 10 or 12 cores, or sometimes they'll do it just targeted. So this is the kind of probably most popular way to do it. Most transrectal, it's the most widely available, but this newer type is called a transperineal biopsy. And this is where, again, you still have an ultrasound probe going into the rectum to localize the prostate here. But instead of the needle passing through the ultrasound probe, it's passed through this little grid here. And so you take samples through what's called the perineum, which is sort of the skin tissue between the scrotum and the anus, that kind of skin tissue back here. And I'll get to the differences here. So a transrectal biopsy, it's generally pretty available because lots of hospitals have the devices that are needed for this type of procedure. It's less painful, if you can believe it. Some people don't really get too much pain from a prostate biopsy, but a lot of people tell me that they don't want to have it ever again, and I don't blame them. The one big risk, I mean, both options do have a risk of bleeding and infection, but with a transrectal biopsy, you're passing through the colon, and so you're passing the needle through a pretty dirty area. So we give you antibiotics to reduce your risk of infection, but there's always a risk of urosepsis or an infection in the bloodstream, making you really sick. So that's why your doctor would say if you get a fever after your procedure, you need to go to the hospital and get checked out. With a transperineal biopsy, the main benefit of this is that there's less infection risk because you're not passing the needle through the rectum to get to the prostate. You really greatly reduce your risk of sepsis, and it takes it down close to 0%. You still can get skin infections in that, but from what I've read and from what I've heard from other clinicians who do this, like Vancouver, they haven't had a single episode of sepsis in my friend's 2 years of practice so far. He hasn't seen it. So, and I've seen probably 2 in the last month of all the prostate biopsies that I've seen. So it is a big difference. The other benefit with the transperineal approach is you can obtain samples from certain regions that you just can't get to with the rectal ultrasound. And so this is more for anterior lesions or lesions in the front part of the prostate that are a little deeper, just because it's you can get around the urethra a little easier when you're passing the needle. I'll show you this here again. This here you can see on my pointer is the urethra passing through the center of the prostate, and in order to hit a target in the front part of the prostate up here, it is difficult to get there without going through the urethra. And if you go through the urethra, you can have a lot of blood in your urine, and it can increase your risk of sepsis. So using the transperineal approach, you can target those lesions if you've had an MRI. You can target those a little bit easier. The downsides with a transperineal biopsy is that you need special training because it's a newer technique, and you also need special equipment in order to perform these procedures. So this makes it less available. They're doing it in Vancouver for sure, and I think they're starting to bring it online in Victoria. I don't know, Holly, do you know if transperineal biopsies are being done here yet? Not yet. Okay, so still just Vancouver, but hopefully you have a little bit more time and training, then we can bring that to the island. But hopefully more to come on that. And the thing with transperineal biopsy is it is more painful. So, but you save yourself the risk of a bad infection, so it's kind of a trade-off. So this is an image of an MRI. So some of you may have had these. It's becoming more and more common in the initial workup and diagnosis of prostate cancer. It looks like a bunch of black and white and gray blobs, but there is actually some anatomy that you can see here. This right here is the prostate. And you can see these little circles within it. And these are little nodules. And every prostate usually has a few little nodules, and we grade them. And so some appear like more like cancer, and some appear more like benign nodules. And I'll get to that in a second as well. Here's the bladder, this big white blob here. This is on top of the prostate, and then the urethra passes through it. There's a penis down here. This is the backbone or the sacrum. So that's where your kind of tailbone is. And then the rectum is right here in front. I'm gonna have to take my word for it. It looks a little bit confusing, but that's why we have radiologists. They help figure out what we're looking at. With MRI lesions, you may have heard, if you've had an MRI, you may have heard of a PIRADS lesion or a nodule score. It's scored out of 5. And so the higher your score is, the higher risk that nodule contains a prostate cancer, or a clinically significant prostate cancer, we call it. So generally speaking, we'll recommend biopsies for PIRADS 4 and PIRADS 5 nodules, because these are the most likely to contain prostate cancer that we're going to need to do something about, or do an intervention or recommend treatment. You can see on the graph on the right, sorry, my there is. The black lines here are the chances of finding a clinically significant prostate cancer, and on the rows on the bottom here, this shows you your PIRADS score. So PIRADS 1 would have a 99% chance that it's a benign or non-clinically significant prostate cancer, and a nearly 1% chance that there's a significant prostate cancer, whereas a PIRADS 5 has a roughly 87% chance of finding a clinically significant prostate cancer. And you can see for 4, it's 71% chance of finding a clinically significant prostate cancer, and then PIRADS 3, the scale kind of tips, 12% chance of a clinically significant prostate cancer. So generally, we only biopsy the 4s and the 5s because the risks of a biopsy then at that point outweigh the risks of missing a clinically significant prostate cancer. So 1s, 2s, and 3s generally we watch. Generally. When you go for a biopsy, if you've had an MRI, there's a few ways that the radiologist can do the biopsies. So they always use the ultrasound because that's how you guide the needle into the prostate. And they either use a cognitive fusion if you've had an MRI, or they use an MRI guided, which is a software-based technique. So cognitive fusion, the radiologist takes a mind map of your prostate MRI image and overlays it with the image they're seeing on the ultrasound. And they sample the region of the prostate where they feel that nodule is located. Good thing with this is it's accessible, so all radiologists basically can do this because they just think in their mind where the prostate nodule is going to be and then targets that area. It's good for larger lesions because you're more likely to hit the target. It's like if your bullseye on a dartboard is 5 times the size, you're more likely to hit it. MRI guided uses a software to meld the MRI and the ultrasound together while they're using the probe. And so it's like a cheater that they can overlay the images together so they can really pinpoint the location of the nodule. And I'll show you an image about that later. One thing is it's very expensive to buy the piece of equipment, the software that runs this fusion technique. And so really we use it for smaller lesions or if the facility already has the equipment. So Victoria does have this capability. We don't have it in Duncan, so we do cognitive fusions, or our radiologists do cognitive fusions there. But so if there's anything that's small, or if it's had a prior negative biopsy, then I may send it for a second biopsy in Victoria where they have this fancy software just to increase the diagnostic accuracy. So it's better for smaller lesions or things that have been previously biopsied and negative, but you still have a strong index of suspicion. So here's that MRI guided or fusion technology. The image on the left side of the screen is the ultrasound image, and you can see there's some, if you kind of behind the red dots and the yellow letters, you can see there's kind of almost like a whitish nodule here, and then kind of this whitish nodule over on this side. And so this radiologist was able to use the computer program to make a representation of this lesion. And then the software tells the person exactly where to pass their needle in order to hit the target that they've chosen on the screen here. So it's kind of a nice little way to precisely target these areas to make sure you're hitting the right spot. Prostate cancer grade, this is kind of your Gleason score that you would have gotten from your doctor. It tells you, it's a scale or a score that tells you how aggressive your cancer is. The higher your Gleason score, the more aggressive your cancer is typically, and the higher risk it becomes. So the numbers is very strange and it's confusing for everybody, including me sometimes, is they take the most common pattern of prostate cancer that's found under a microscope and compares it to the second most common pattern. So if you have a Gleason 3 + 4 = 7, that means that most of the cancer within the prostate core is a 3, but there's also some 4, which is a higher risk type. So then they just add those two scores together to get your final Gleason score. So if you had a lot of Gleason 4 in your, or pattern 4 in your biopsy sample, but a little bit of pattern 5, then you get a Gleason score of 4 plus 5 equals 9, which is a higher risk type of cancer. You can also, if you read your biopsy report, sometimes they mention a tertiary grade, which is then the third most common or the highest risk type of prostate cancer in the biopsy core. So you may have an intermediate risk, which I'll get to that in a second. Gleason 4 plus 3 equals 7. So most common pattern 4, second most common pattern 3. But if there's a tertiary pattern 5, that means there's just a small amount of this higher risk cancer, but it's worth mentioning. So even though the overall score would be 7, the pathologist is alerting the urologist and the doctors that there is a little bit of this high risk group within the core as well, because that can have implications as well. Some of the nomenclature or kind of wording that you may see on your prostate biopsy, I thought this would be important because a lot of times I get questions about what does the different fancy pathologic terms mean. Adenocarcinoma is sort of the general run-of-the-mill prostate cancer. It's the most common type that you'll see, and acinar type is a subtype that is kind of the routine, most common type of prostate cancer. Intraductal carcinoma is a more aggressive form, and it's just another architecture that the pathologist sees under the microscope. Cribriform glands is another thing that's a bit more aggressive, and so you may see this on pathology reports as well. Neuroendocrine carcinoma is a different kind of type of prostate cancer that sometimes we see, but it's fairly rare. This one generally is very aggressive and presents with low PSA numbers. And generally, you can see people who are metastatic or have spread of prostate cancer at the time of diagnosis if it's not caught early. And sometimes we see this post-treatment, but it's not very common. But in case you ever see this or hear of one of your colleagues or friends with this type of tumor, it can be more on the aggressive side. Perineural invasion and extraprostatic invasion or seminal vesicle involvement. These are other things you may see on your prostate biopsy sheet. And these are just perineural invasion indicates a little bit more aggressive cancer that is starting to invade into the neurovascular bundles or little bits of nerves around the prostate. So it's sort of an early sign that it's aggressive. And then extraprostatic invasion or seminal vesicle involvement in the early part of the presentation where I showed that prostate anatomy, that little structure that held the food for the semen. That's the seminal vesicle. And so the prostate cancer can grow up the ducts and into the seminal vesicle. And sometimes you see that on your prostate biopsy. So that's an indication that the prostate cancer is starting to move outside of the prostate already. This is just an example. This is an example of a pathology form, a synoptic report from one of my patients. And you can see that the pathologist has done a systematic biopsy. So this is a non-targeted, just for somebody with an elevated PSA with no prior MRI. The highest grade was the highest Gleason grade that was found in all of the cores. So they look at 12 cores. They say the core that had the highest cancer was a 4 plus 3 equals 7. But overall, the average score, the most common core that they saw was a 3 plus 4 equals 7. So the overall score would be 3 plus 4 equals 7, but the highest risk is also worth knowing about is a 4 plus 3 equals 7. They also usually tell you how much of each pattern is there or what the most common is. So percentage of pattern 4 is 30%. So then you know that probably 70% of the remainder of the prostate cancer is a pattern 3 or the lower intensity. So this patient had some cribriform glands present, but no intraductal component. 8 of their 11 cores were positive. And No periprostatic fat invasion or seminal vesicle invasion was seen. So this is a localized prostate cancer as far as we know at this point. People ask about stage and what stage they are. Stage 1 is where the tumor is, usually if the tumor is picked up on a prostate resection. So this would be for if someone has a catheter or can't pee very well, we can do a surgery to shave away the inner part of the prostate to get them peeing better. So stage 1 is when we pick this up on a TURP or a transurethral resection of the prostate. Anyways, there's different percentages and ways that you can be in a T1A or T1B. T2 or stage 2 is where you feel a prostate nodule and then you have a biopsy confirming this, but it's localized to within the prostate itself. Stage 3 is when it protrudes outside or through the prostate capsule or right at the border of the prostate wall. And then T4 is when it's invading beyond the seminal vesicles into the bladder or into the sphincter or into other surrounding structures. So there's tumor staging, so that's the T. So the ones we talked about there, T1, T2, T3, T4. And then there's also nodal staging. So if there's lymph nodes, that prostate cancer generally likes to spread to the lymph nodes. That's one of the early spots that it likes to go. Either you have no lymph node spread in your N0, or you have spread in the lymph nodes in your N1. Just the way that doctors can quickly communicate between each other how aggressive or where this prostate cancer is. So if I say to somebody he has a T2A N1 M0 cancer, then they can quickly think in their mind without me saying, this person has less than 1/2 of one lobe of prostate and pelvic lymph nodes and no metastases. It's just a quicker way for us to kind of get our point across to each other. The M staging is for metastases, and this is whether or not there's any spread within the pelvis, outside of the pelvis, if it's in the bone, or if it's in soft tissues and all. I'll talk a little bit about how we tell whether or not it's outside the prostate in a minute. You may also hear us talk about localized or metastatic, castration sensitive or castration resistant. These are all terms that you will hear at some point throughout your journey with prostate cancer. Generally before surgery or at your initial diagnosis, you'll hear either localized or metastatic cancer. Localized means it's within the prostate and has not spread. Metastatic means it has spread outside the prostate. Within metastatic prostate cancer, we classify them in either low volume or high volume, and this is based on a few different criteria. There's different sets of criteria that we use to dictate this, and this is just a way to determine which kinds of treatments may be available for you based on how much cancer has already spread. So there's certain treatments that you can only give for people who are low volume metastatic, and then there's some that you can only give if they're high volume metastatic. Castration sensitive is a term that sounds terrifying, but it means that the prostate cancer is going to be responsive to castration or androgen deprivation therapy. So this is the injections that your doctors may have told you about, something that helps to treat prostate cancer. And how this works is prostate cancer generally feeds on testosterone. It's sort of the fuel supply for prostate cancer. And so in order to blunt the growth of prostate cancer, we shut down the testosterone production. In the old days, it was with castration, with removal of the testicles, but generally guys are kind of attached to those things. So we've created medications to help do that for us. Eventually, the prostate cancer can become resistant to this, and then you develop castration resistance. So that's when your prostate cancer no longer responds to androgen deprivation therapy. And there's other treatments that we can give that helps to combat that. So you may hear those terms. So lots of times, patients, when they're first diagnosed with prostate cancer, we talk about staging. And how we do that is with imaging. And I'll talk to you about the different forms of imaging that we classically use. Sometimes people don't get staged, and the reason is because they either have a low risk cancer or they don't meet criteria for staging. And we just go based on the amount of prostate cancer that we see on the biopsy and what the kind of risk type is. Some intermediate risk prostate cancers do not require staging, but all high risk cancers need staging. So the higher your Gleason score is, the more likely you're going to need staging. And if it's a low risk type, you generally won't need staging. So how do we stage? So remember that scale from T1, T to T, N, and M. T is the local prostate cancer, the N is the lymph nodes, and the M is the metastases or into distant structures. The usual first test that people will get is a CT scan or the CAT scan. This is a pretty quick procedure. It takes 10 minutes into the big donut, and generally we would do a chest, abdomen, and pelvis. So we scan from the neck to the pelvis. This looks for spread of cancer into soft tissue. So it's good at looking at lungs, liver, lymph nodes, and also you can see some sclerotic or bone spots or bony spread from prostate cancer, but it's not the best test for looking at bony metastases. So that's where we use a different test, which I'll get to in a second. This is just Google images I pulled off of the internet. These are two different representations of a CT scan. The one on the left is the person is standing with their head at the top of the screen and their feet at the bottom. And you can see these black things here. These are the lungs. This structure here is the heart. The liver is this wedge here. And you can see this kind of black, pebbly looking thing here. This is the colon with stool. And this wraps around the whole abdomen here. These are the pelvic bones here. And these little circles, that's the hip joint right here. And then this big ball in the pelvis, this is the bladder. So this is a good way to look at soft tissues. You can see it, you see a spot in the liver or a spot in the lung, then you say, well, maybe that could be a prostate cancer. Maybe we should look at that and offer treatments accordingly. This CT scan is a slice through a patient that's lying down flat. It's almost like the magician cutting a person in half. This is what it would look like. And you can see that this arrow is pointing to this little gray dot here. This is a small little lymph node metastasis of prostate cancer. The second scan that we'll get you to have done is called a bone scan. And so this is better at looking for bone metastases. It's a longer procedure and it's only offered at sites with a nuclear med scanner. So we don't have this in Duncan either, but this is done in the Royal Jubilee site. And then there's one in Nanaimo and in Courtenay as well. It takes about 3 or 4 hours. So it's a bit of an afternoon event. The reason is you have to have an injection of contrast or radio tracer that is injected into the IV, and then you have to give it a few hours to get absorbed by all the bones so that you can then detect it on the scanner. And it helps to really clarify whether or not the bones have any tumor, and if there was any of these little white spots on a CT scan, determine whether or not they are cancerous or not. Because there are different things that are benign that can cause white spots on your bone on CT scan. So it helps to clarify that. This is what a bone scan would look like. Both of these patients, there's 2 patients. The 2 bodies here on the left side of the screen. This is one patient facing, this one, the far left is the patient facing away from us. And then this one is the patient's facing us. And you can see this big black circle here, this is the bladder. And these little black dots all up and down the vertebrae and in the shoulder and in the ribs over here, there's a couple spots. These would be bony metastases or spots where bone is turning over or having a lot of activity or cell growth. And so these spots will light up, and that's likely to represent a metastatic deposit. This patient on the right side of the screen, this person has a lot of metastases throughout the whole spine, the ribs, the pelvic bone, the femurs, shoulders, even the neck and the head. This is how a patient has kind of progressed through prostate cancer from 2019. You see that there's this gray blob, and it's going to have to believe me, but this is a lymph node here that the arrow is pointing to. And then this person, I think, did not receive any treatment over the course of a year. And you can see that the transition, and now this gray spot is bigger. So that node has gotten bigger over time since they weren't on treatment. And then another 1 year later, they've now developed this kind of, you can see the vertebrae here. This is the backbone. And normally a backbone would have kind of a white periphery and then a kind of more darker internal portion. But this bony structure here, it has this kind of white piece where normally it should be nice and dark in the middle like this one. You can see it's more white. So they thought, well, maybe this is a cancer metastasis. Let's get a bone scan. And then the bone scan shows activity in that same location. So that would confirm that it is more than likely a prostate cancer metastasis. The new kid on the block is this thing called a PSMA PET scan. This is just now available in Victoria over the last couple of months, I think 3 months, yeah. So that's really exciting for patients in the island, because it used to be you had to go to Vancouver, and before it was widely available in Vancouver, publicly funded, people would have to pay for it privately, which would be very expensive. It's used for different reasons. It helps to increase the detection of prostate cancer when there's nuanced circumstances, which I'll touch on. It's more specific for picking up prostate cancer, particularly if there's any ambiguity in the CT or the bone scan, because as you saw in these images before, you're kind of looking at these smudgy black and white images, and you kind of squint your eyes and you think, is that a real spot? Is it not? I'm not sure. So this can help increase the detection of those kind of questionable spots. Very expensive compared to CT and bone scan. So we only use it when we really need it, because it is quite costly on the system. Private pay is an option, and it can be somewhere in the order of $4,500, I believe, if you want to pay for this privately. This is what a PSMA PET scan looks like. If you can see this image on the left, it looks similar to a bone scan, but it's also lighting up different organs, soft tissue organs, like these black globs here. These are your kidneys. And then you can see this faint gray structure here. That's the liver. And you can see that this person's got black spots all over the bones. That's where the PSMA PET scan tracer is getting picked up by those bony areas as well. And usually you'll do a CT scan at the same time as your PSMA PET, and you can overlay the two images, and then you get these really beautiful scans where you can see, it's like a heat map, where you can see how intense the signal is based on the CT correlation. So you can see this arrow here is pointing to a small little lymph node in the abdomen. And then this big red one here means there's a really high uptake in the bone in this location, and then also in the pelvic bone over here. So this has been really a game changer in helping detect previously undetectable prostate cancer. Here's another example. You can see here some rib metastases here with the arrows on the front and the back side of the patient, and then the correlate on the CT scanner, these big bright red dots. These are the ribs around the chest. And you can see these big black structures here. This is the lung, and then this is the heart here. So these are little rib spots that have metastases from prostate cancer. So when do we do this? I mentioned it's kind of when we are having difficulties confirming the diagnosis or finding where the cancer is, particularly for men who have had a recurrence of their prostate cancer, but we do use it in the staging of local prostate cancer as well. Generally with localized prostate cancer, if there's any question about whether a scan is positive for metastases, it's better to confirm with a PSMA PET scan so that you make sure that if you're offering curative intent treatment, that you're doing it for a patient who's actually going to benefit from it. You don't want to take somebody's prostate out if they have a spot in their rib that isn't going to get treated by just a simple prostate removal. So this really helps to really get people on the right treatment. If anybody has very high risk localized prostate cancer, we can do this. Or if someone has spread of prostate cancer and they're considering treatment of those metastases, usually those are very no-no situations as well. Where it's really helpful is in biochemical recurrence, or if your PSA starts to go up after treatment, then it can help to detect where that prostate cancer or where that PSA is coming from so that you may be able to have treatment just to that site of metastasis. Then it's also an option for patients who are looking for PSMA targeted therapy like lutetium or what's the fancy name for it? Pluvicto is the new kind of PSMA PET targeted treatment. You can also get it if there's special situations, but it needs an interdisciplinary group. Yeah, so after your initial prostate treatment, generally people will be monitored with PSA. You kind of go back to PSA surveillance. And many people will get repeat imaging, both in a CT and bone scan, the standard. If your PSA starts to rise, if there's big variations, or if you have any kind of clinical suspicion for spread of prostate cancer. So 10 years after your prostate's removed, if you're all of a sudden now you got a really sore back or your ribs are hurting or something, then may want to think about restaging with a CT and bone scan to see if there is a site of prostate cancer metastases. That's kind of it for the diagnostics and some of the newer kind of techniques and what you may expect either during your diagnosis and workup of prostate cancer and beyond. And thanks, Holly, for having me. And I'm happy to take any questions from the audience or from online as well.